Welcome back to Catalyst University. My name is Kevin Tokoff. Please make sure to like this video and subscribe to my channel for future videos and notifications. And a big thank you to my patrons on Patreon for your contributions to my channel. In the previous videos, we extensively discussed the major muscles involved in deglutition, which is a fancy term for swallowing. And we pretty much covered everything in this diagram right here, except for the transition of the bolus of food from the end of the laryngopharynx into the esophagus. And of course, we haven't discussed the esophagus yet. So that's what we're going to look at in this video. And this is really just a continuation of deglutition, swallowing, in the esophagus. So swallowing essentially ends once we get that bolus of food down into the stomach, because from there, it really just is mechanical and chemical digestion of the contents of the foods into little bitty amino acids, sugars, and lipids for absorption and utilization. Let's first look at some relevant anatomy. So in green here, spanning all the way from the top here, all the way down here past the diaphragm and essentially merging with the stomach, this is your esophagus. And lying anterior to the esophagus, right here at least on the top, is the trachea. If you look at the trachea right here, you can see these rings that go around it. These are the tracheal cartilages. And these cartilages play a role in keeping the trachea patent, which basically means keeping it open. It doesn't close, it doesn't constrict, it maintains the airway open. And that's important to understand. In contrast, the esophagus that lies posterior to the trachea is going to be held closed most of the time. It's not open. And the only time the esophagus actually opens is when we swallow a bolus of food. And the esophagus essentially opens in proportion to the size of the bolus. So if we have a small bolus of food, maybe some liquid, it's not going to open all that much, just enough to allow entry and passage of that liquid down into the stomach. But if it's a large bolus of food, maybe we swallow too much, the esophagus will open a lot. Okay, so by default, it's held closed, which is the opposite of the trachea. Now, as the trachea descends inferiorly into the thoracic cavity, you can see that about at the level of the heart, it's going to bifurcate into a left and right primary bronchi, and each one individually is a primary bronchus. And so right here at the tracheal bifurcation, that's where the trachea ends. So you can see that the esophagus is actually quite long, much longer than the trachea is. Now the heart would sit right here, and the heart would be anterior to the primary bronchi, which are in turn anterior to the esophagus, which in turn is actually anterior to this aorta. Remember, off of the left ventricle of the heart, you have the aorta that comes off. So this would be where the ascending aorta is. Here's the arch of the aorta, and then it turns around into the descending aorta. And this part of the descending aorta, superior to the diaphragm, is the descending thoracic aorta. That thoracic aorta, notice, is not only behind the esophagus, so posterior, but it's also a little bit to the left of the esophagus. Okay? The walls of this part of the thoracic cavity over here, kind of in gray, this would be the left parietal pleura, one of the serous membranes. Over here would be the right parietal pleura. Up here would be the superior vena cava that's going to bring blood from the upper extremities and also the neck and the head back to the right atrium of the heart. Now the inferior vena cava has been removed, but I want you to notice down here, this is the hiatus of the inferior vena cava. A lot of these structures that are in the thoracic cavity have to move between the thorax and the abdomen, and there's obviously a barrier, and that's the diaphragm. And so the diaphragm actually has several holes in it, and most of them are called hiatuses. Each one is a hiatus. So this one right here is the hiatus of the inferior vena cava. So what you can speculate here is that because this hiatus lies anterior to the esophagus, that the inferior vena cava is also anterior to the esophagus, but a little bit to the right of it. So anterior and right, whereas the thoracic aorta is posterior and a little bit left. Okay. Also right here, this would be the esophageal hiatus. And this is the hole by which the esophagus actually traverses from the thorax into the abdomen. And you can see right here where it actually exits the esophageal hiatus through the diaphragm and essentially becomes continuous with the stomach, which is right over here. Note that there would also be an aortic hiatus back here just behind the esophageal hiatus and a little bit to the left of it, that allows the thoracic aorta to descend from the thorax into the abdomen. Once it crosses into the abdomen, it's called the descending abdominal aorta. And then of course down here you have the right hemidiaphragm, which is the right half of the diaphragm. Now this picture on the left here is showing for an average person the distances between the upper incisors here, so basically the mouth, ultimately to different parts of the esophagus and all the way down to where the esophagus blends into the stomach at a region roughly at the lower esophageal sphincter called the esophageal gastric junction. If we look here, the distance between the upper incisors and the upper esophageal sphincter right here, this is about 15 centimeters. And really, where the upper esophageal sphincter resides, that marks the start of the cervical esophagus. And so if we look from 15 centimeters to about 20 centimeters, this distance right here, that's the cervical esophagus. From 20 centimeters down to 25 centimeters, this would be the upper thoracic esophagus. From 25 centimeters to 30 centimeters, this would be the middle thoracic esophagus. And then from 30 centimeters all the way down to 40, which is basically where the lower esophageal sphincter is, this would be the lower thoracic esophagus. And at 40 centimeters here for an average person, this is going to be roughly where the esophagus starts to blend into the stomach, and we call that the esophageal gastric junction. Now answer this question. When you initiate swallowing, swallowing is of course voluntary, do you have to consciously think about contracting your pharyngeal constrictor muscles? Yes, those are voluntary muscles. When you initiate swallowing, you are essentially causing your pharyngeal muscles to contract all the way from superior down to inferior, and those are voluntary skeletal muscles. Now, when we get to the esophagus and we're propelling food from the esophagus down ultimately into the stomach, do you have to consciously think about those muscles? And the answer is no. You initiate swallowing up in the pharynx, right? The oral cavity in the pharynx, but then the esophagus kind of does it on its own. So it's involuntary, so it must be smooth muscle, right? No. Contraction of any muscle in the esophagus is involuntary. However, it has a mixture of muscle types. It depends on what level of the esophagus we're at. So if we look up here at the top where the pharynx kind of blends into the esophagus, and really the upper part of the esophagus, it is skeletal muscle or striated muscle, but it's involuntary skeletal muscle, not consciously controlled. Near the bottom, down here, the bottom of the esophagus where it will blend into the stomach, this is all smooth muscle. And then in the middle, it's a mixture where you have less and less and less skeletal muscle and more smooth muscle. So it's a blending of the two. So near the top, closest to the pharynx, is skeletal muscle. Near the bottom, closest to the stomach, is smooth muscle. And in the middle is mixed, and all of it is involuntary. What we have here is a zoomed-in view of the upper part of the esophagus, and up here is actually the laryngopharynx. And the gatekeeper that controls whether or not a bolus of food can move from the laryngopharynx into the esophagus is the upper esophageal sphincter. What you see right here is the baseline state of the upper esophageal sphincter. It's actually contracted. That's the baseline state. And while this is contracted, it's preventing movement of anything, including a bolus of food, from the laryngopharynx into the esophagus. Conversely, it also prevents movement of things in the reverse direction from the esophagus here up into the laryngopharynx. And the way this upper esophageal sphincter is maintained in this contracted state is through a tonic stimulus through the vagus nerve, cranial nerve 10. So the vagus nerve is actually sending motor output to the upper esophageal sphincter, which maintains this contracted state. And so if we have a bolus of food in the laryngopharynx and we need to get it down to the esophagus, this upper esophageal sphincter better relax. And the way that occurs is through a release of this motor output by the vagus nerve. So the vagus nerve is going to have to release its control of that sphincter in order to allow it to relax and for this lumen to open up. Now obviously that bolus of food is going to have to be propelled from the upper esophageal sphincter down through the esophagus to the lower esophageal sphincter, the function of which we'll cover in a few minutes. And that propulsion of the bolus through the esophagus is done through peristalsis. And so you're going to use skeletal muscle to use peristalsis at the top, a mixture of both of these, skeletal and smooth muscle in the middle, and then only smooth muscle closer to the lower esophageal sphincter. But in order to use muscle, you have to have nerves, and the nerves have to innervate these muscles. So what is the overall innervation of the esophagus? Well, it really depends on what level you're at. So up at the top here, this is the pharynx, really the larynx. But of course, we're considering where the pharynx blends with the esophagus, and that region of the esophagus, the cervical esophagus that is innervated mainly by the pharyngoesophageal nerves. If you look here carefully and track these back up, you can see these are ultimately coming from the vagus nerve, specifically the pharyngeal branch of the vagus nerve. So yes, the pharyngeal branch forms the pharyngeal plexus, which innervates a lot of those pharyngeal muscles, right? But you can see it gives off a branch here that's going to go down to the lower parts of the pharynx and then also down to the esophagus. And that's going to be those pharyngoesophageal nerves. If we go to the middle of the esophagus, we're looking mainly at the para-recurrent laryngeal nerves. So look carefully. If we follow the vagus nerve down, let's say on the left here, remember that the vagus nerve is going to give off that recurrent laryngeal nerve. So right here, this is the left recurrent laryngeal nerve. Over here, this would be the right recurrent laryngeal nerve. Now, if you look carefully, there are no branches actually coming off of the recurrent laryngeal nerves. Those actually go all the way back up to the larynx. But if we look carefully, there's a branch coming off of the recurrent laryngeal nerves called the para-recurrent laryngeal nerve. So right here, this is the left para-recurrent laryngeal nerve. And now you can see those branches coming off. And they extend from the middle esophagus all the way up to the upper esophagus. You can see the same thing on the right side. Here's the right recurrent laryngeal nerve, no branches to the esophagus. It's going all the way up to the larynx. But we do see that right para-recurrent laryngeal nerve coming off of here to give some in the middle esophagus and then ultimately going up to the upper cervical esophagus. Now, if we keep following the vagus nerve down, yes, they give off the recurrent laryngeal branches, but they keep going down. There's even more branches here. But what we see is that the left vagus nerve is going to exchange some nerve fibers with that of the right vagus nerve. Okay? And when they combine, you see here one major branch that goes anterior to the esophagus. This is what's called the anterior or ventral vagal trunk. Now, the anterior vagal trunk is going to contain both left and right vagal fibers, but the anterior one is mostly the left vagus nerve. This one in a dotted line right here is meant to show that it's behind the esophagus, it's posterior. So this is the dorsal or posterior vagus trunk. It also contains fibers from both the left and right vagus nerve, but the posterior one is mostly the right vagus nerve. And you can see as these fibers intercross between the left and the right, and once they form the ventral and dorsal vagal trunks, they give off a bunch of branches which help innervate the remainder of the esophagus. Really, some of the middle esophagus up here down to the lower esophagus at the bottom. So through that innervation that we just talked about, these muscles contract in a peristaltic manner to propel that bolus of food down here to the bottom of the esophagus, where it's going to encounter the lower esophageal sphincter, which I have there circled in gold. Now what we see right here in this picture at the top, this is the bottom part of the esophagus where it's going to blend with the stomach. Now this thing right here is the Squamo columnar junction, which essentially is the junction between the esophagus and the stomach, but it's expressed here in terms of the cell type. Now let's think about this for a second. The stomach has to have protection against what? Well, stomach acid, right? There's stomach acid in the stomach, and it can cause the pH of the stomach to drop to 1 after a meal. Very, very acidic in there. And so within the stomach mucosal lining, it's mainly columnar cells. And interspersed in those columnar cells are mucus cells that secrete mucus, and the mucus coats the lining of the stomach and protects it from the harmful effects of stomach acid. It just so happens that the cell type in the stomach is columnar. But if I went to the esophagus and asked you, okay, for the mucosal lining there, what are we trying to protect against? With the exception of gastroesophageal reflux disease, the acid's in the stomach, not in the esophagus. In the esophagus, we're protecting against abrasion. When we swallow food, that food moves down the esophagus, right? And it can scrape off cells that line the lumen, the mucosal cells. If we're scraping off cells, we need to be able to regenerate cells quickly and also have multiple layers of cells. So it would make sense that the lining of the esophagus is actually stratified squamous epithelium, okay? And so in this area right here called the squamo-columnar junction, it's a transitional zone between the stratified squamous cells in the esophagus and the columnar cells in the stomach. And so at the squamo-columnar junction, you have a transitional zone where you're blending from one cell type to the other. Now right over here we have the lower esophageal sphincter, which actually has two components. There's an internal part, which is of course deeper and closer to the esophagus, and then the outer part is the external part of the lower esophageal sphincter. They're only showing it here on the right side, but it technically also exists on the left over here. What we're also seeing over here is the diaphragm. Remember, the esophagus is having to pass through the esophageal hiatus. This hole in the diaphragm right here is essentially that, the esophageal hiatus. And so there's a couple different parts of the diaphragm. We have the costal part over here, and that transitions into the crural part of the diaphragm, and that's the part that's actually in indirect contact with the esophagus. Okay? But just remember that with the lower esophageal sphincter, it does exist on both sides. They're just trying to show the components of the diaphragm over here. Now, the lower esophageal sphincter here functions very similar to the upper esophageal sphincter. It serves as a gatekeeper from the bottom of the esophagus into the stomach, and also by default, it's in this contracted state. And that contracted state is maintained through the tonic stimulus from the vagus nerve. And in order to allow that bolus of food to go from the esophagus into the stomach, we have to release that tonic stimulus, and the lower esophageal sphincter is going to have to relax. So it functions very similarly. We'll go into that in a little more detail here. So what you see at the bottom right there, that is the lower esophageal sphincter. Again, it exists on both sides, actually completely around the circumference of the esophagus at the bottom, right? So up here would be the esophagus, and down here is the stomach. Now, if you look at these red motor output fibers, they're ultimately coming from this red nucleus right here within the medulla oblongata called the dorsal vagal nucleus, or the dorsal nucleus of the vagus nerve. Like I said, it's contained within medulla oblongata. And by default, most of the time, it's sending these motor output signals to the lower esophageal sphincter to maintain its contracted state. And as long as it's contracted, it's closed off here and preventing things from moving from the esophagus into the stomach. But here, and probably more importantly, preventing things in the stomach like acid from moving into the esophagus. If this were to fail for some reason, stomach acid would more easily move into the esophagus, and that condition is called gastroesophageal reflux disease, or GERD. We'll be covering that in more detail in another video. So if we want the lower esophageal sphincter to relax, to allow the bolus to move from the esophagus into the stomach, we of course have to release this tonic stimulus on the lower esophageal sphincter from the dorsal nucleus of the vagus nerve. Now, how does it know to do that? Well, look at this blue sensory fiber right here. So this is a sensory fiber that's sensitive to stretch of the lower esophagus. What's going to happen if there's a bolus of food waiting in the lower esophagus? Well, it's going to stretch the walls of the esophagus there. Well, that stretch is sensed by this blue sensory nerve. It's going up here, and it's ultimately going to this blue nucleus also in the medulla oblongata called the solitary nucleus. Sometimes they'll call it the nucleus tractus solitarius. I prefer solitary nucleus. And the solitary nucleus processes that stretch information and relays it back to the dorsal nucleus of the vagus nerve, and that causes this dorsal nucleus to release the excitation and release that contraction of the lower esophageal sphincter, and that allows it to relax, and the bolus of food that was stretching the walls of the esophagus right here can now move into the stomach. What would happen if there's nothing in the lower esophagus right here? Well, then there's no stretch, and the solitary nucleus senses there's no stretch, and so it allows the dorsal nucleus of vagus to continue that contraction of the lower esophageal sphincter. Why? There's nothing to move into the stomach, and we need to maintain that closure here to prevent stomach acid from moving into the esophagus. Now, we've already talked about the types of muscle tissue that you have in the esophagus depending on what level of the esophagus we're at. The upper esophagus is skeletal or striated muscle, the bottom is smooth muscle, and the middle is a mixture of the two where skeletal muscle is blending into smooth muscle. But what we haven't talked about are the layers of the muscle cells. And this is more appropriate to talk about in the smooth muscle regions at the bottom of the esophagus. Right here you see the diaphragm, and this is the esophageal hiatus, where the esophagus is actually moving inferiorly through the diaphragm, where it will very quickly blend with the stomach. Now what do you see here? Inside here is the lumen. This is the hole in the center of the tube where the bolus of food moves through. And the mucosa is composed of stratified squamous epithelium. We covered that. That's the multiple layers of squamous cells that are to protect against abrasion. When food's moving through, it scrapes some of those cells off, and so they rapidly proliferate to replace the lost cells, but it also provides multiple layers so that we're not damaging deeper tissues through that abrasion. Okay? Now, around the mucosal layer, we have the submucosal layer, which has esophageal glands embedded in it. Now, the stratified squamous epithelium provides protection by means of multiple layers. So that way, if we abrase some of the layers off, we can easily replace those and not damage deeper tissues. But one of the other ways we can protect against abrasion is by lubricating the lumen of the esophagus. And so these esophageal glands in the submucosal layer, they're going to secrete mucus that ultimately winds up coating the mucosal layer on the luminal surface. And so when food moves through here, not only are the stratified squamous epithelial cells prepared to rub off, but also it's lubricated to provide for easier passage and more protection through the mucus secreted by these esophageal glands. Now, around the submucosal layer is the muscularis externa, or the muscular layer. And in the esophagus, there are two layers of muscle that help with this peristalsis of moving that bolus of food towards the stomach. And there's an inner circular layer and an outer longitudinal layer. In general, as we go through the GI tract, the circular layer is going to be the inner one, and the longitudinal layer is going to be the outer layer. When we get to the stomach in the next video, we'll actually see that there's a third oblique layer, but the esophagus only has two layers, inner circular and outer longitudinal. And sandwiched in between these two layers is what we call a myenteric plexus. So if you look here, this right here is your outer longitudinal layer of muscle. This is your inner circular layer of muscle, and sandwiched in between those, you have this plexus, the myenteric plexus. This plexus gets in between the two muscular layers and ultimately comes from branches of all those nerves that we talked about several slides ago, whether it's the pharyngoesophageal, the pararecurrent laryngeal, or just branches of the vagus nerves or the vagal trunks that come from those. Little bitty branches of those form those myenteric plexuses that go between the longitudinal and circular muscular layers. And they help to cause these muscles to contract in a coordinated manner that promotes peristalsis of the bolus of food into the stomach. And then the outermost layer here is the serosa. So hopefully this video gave you a good understanding of all the features of the esophagus and how it works. In the next video, we're going to go into the stomach. See you then. Thanks for tuning in. Please like, subscribe, and check out my Instagram for cool science and not science stuff.